It is the top of the hour. It's 1 o'clock, so we're going to start. We are very fortunate today to have the chair of the Department of Surgery of Texas Tech University Health Sciences Center to talk about telemedicine to combat fatigue, burnout during the COVID-19 pandemic. We get the next slide, and we are very thankful to the TexLa TRC, which is supported by HRSA, for this project that we're doing. Next slide, please. And just a little bit of a housekeeping. These are the learning objectives of Dr. Wakefield, and you will be credited with CME and CEU units for this activity. Next slide, please. And make sure you mute your Zoom button. And these are the appropriation for the credit units for your participation in this conference or webinar. So without further ado, Dr. Sarah Wakefield is our Associate Professor and Chair of the Department of Psychiatry with Texas Tech University Health Science Center, as well as the Director of the Child and Adolescent Clinic. She is the real representative of TexLa TRC since she did her training at UT Galveston, of med school at UT Galveston, as well as her residency training in Louisiana State University. And now she's back here in Love of Texas. Take it away, Dr. Wakefield.
Well, thank you so much for having me. I'm really excited to be here. I'm always excited to talk about how to protect our mental health, and so I really appreciate this opportunity. I don't have any disclosures, or at least none that I'm aware of, so we can go ahead and get started and talk about some of our objectives today. We are going to be talking about defining the typical rates of mental illness, suicide, and burnout for clinicians. So what it looked like pre-pandemic. We don't have a lot of information about what it looks during the pandemic, but that's we have pieces of information that we'll kind of talk about. Describe how the current pandemic has affected mental health and mental health care, and then explain how this has affected clinicians specifically. Identify some current screening recommendations, and then how we can use technology to facilitate improved mental health, whether it's looking at exercise apps or accessing mental health care, direct services and evaluation and treatment through telemedicine services. So what has it looked like? What was the pre-pandemic rate of mental illness, suicide, and burnout for clinicians? This is really near and dear to my heart. It is looking like my next slide. Oh, it is. Hold on. Let's see. Yep. All right. So 1 in 4 doctors report suicidal thoughts. This is really big information, really big important information that I think we don't talk about enough. We don't talk about enough in medical school. We don't talk about enough day to day in our clinical work environment about how frequent physicians are feeling those desperate thoughts, really feeling despair. When we think about suicidal ideation, it's a thought of despair. And there are many things that go into that, and we'll talk about it. But 1 in 5 doctors report a diagnosis of depression. And that is they have sought an evaluation and they have gotten that diagnosis. But we see that more than that actually are reporting feelings of despair quite frequently. Then 1 in 50 physicians have engaged in suicidal behaviors. And the rate of depression in medical students outpaces the general population. We lose at least a class of physicians, a medical school class of physicians every year to suicide. There's at least 1 physician death by suicide every single day. I'm going to say this right now at this point that this whole presentation is not going to be focused on suicide. It's really going to be focused on mental wellness, but we'll have some numbers and some places to reach out to if you're feeling triggered by this presentation, or this is bringing more awareness to opportunities to reach out for healthcare, because that's what we want to highlight here. The physicians had 2 to 3 times the rate of suicide of the general population, and then female doctors attempt far less than the general population. but actually complete at a very high rate, equal to that of male doctors. When you look at suicide rates of women and men in the general population, men tend to use more lethal means, and so have a higher death by suicide rate. And female physicians actually equal that rate. I included this because I don't want this to be just focused. This is not a presentation just focused on physicians, but that's where our best data is, because we have no idea. There is a group out of at UC San Diego that in 2018 started tracking nurse suicide and nurse depression rates. But we have very, very little information about anybody outside in the clinical environment other than physicians. So this is not to suggest that those rates aren't just as high or higher, but we don't have that data. So what is going on? Why are people feeling like this? Why is there so much desperation with healthcare clinicians? These are theories, but one of the ideas is that autonomy has decreased. There's less room for creativity. There's more, you have to do it this way, automated processes, someone looking over your shoulder. Did you check all these check boxes at the EMR? Less teamwork, more kind of siloed work within the clinical healthcare team, and less perceivable impact, really, because our relationships with patients are getting shorter. When you think about a hospitalist versus somebody who has an outpatient relationship with someone and then follows them into the inpatient environment, it really has this longer care impact time frame, that some of the things that we've gone to try to have better things, more automation, protect kind of the legal framework of the practice of medicine, and also to try to get a healthier lifestyle outside of work, with more shift work type things, may be impacting the mental health care of our clinicians in a negative way. So in addition to all of that, we are often engaged in high stakes ethical conflicts and what we call moral distress. So really, we're going to talk a little bit more about moral distress and what that means, but how daily, multiple times daily, depending on what environment in which you work, clinicians, healthcare workers are facing huge conflicts in what they can do, what they feel they should do, what family wants to do, what surrogate decision makers want to do, what patients understand and how to explain it to them. And this is very draining. So ethical issues, just to have a little bit of framework on this, when we talk about ethics conflicts, there are multiple options for an action are presented, and we're trying to figure out which one. And anytime you choose one, it affects the other in a negative way. So this presents an ethical conflict, trying to figure out, where do we go from here? What is the least worst decision? Is kind of how I describe it when I'm talking with families. I had the privilege of serving as the chair of ethics at one of our hospitals here for the last 3.5 years until September. And in speaking with families and patients and healthcare workers in resolving ethical conflicts, we often say, what's the least worst thing to do here, and what has the least worst outcome? That's a really hard thing to engage in, and our clinicians are doing that daily. Then the locus of authority. So who has the ultimate moral authority in the situation? Is it the patient? How does the autonomy play a role? Is it the attending physician? Is it the nurse manager? Who is it? And kind of who runs the unit? How does the team function? Where's that locus of authority? I think is a really, if that's not clarified in a teamwork environment and everyone's not on the same page, it creates a lot of ethical and moral distress. And then, as you see, ethical moral distress, recognition of what is right, but the inability to act on it. And just a little bit more on moral distress, really feeling that you're complicit in acting unethically, even if you're not intending to, or doing something that you feel is morally wrong, having little power to act differently or change the situation. We can all see how the pandemic has presented many, many of those situations when you may not have the resources, or you're not able to have a family member come in and be with a patient, because overall that's the safest thing to do. But for this patient who's in distress and really would benefit from seeing their family member, that you have to deal with the outcome of that every day, and seeing that patient suffer. Let's go to the next slide. So the other thing that I want to talk about before we go on to the pandemic is that chronically in the United States, we have gotten to a place of a lot of unhealthy lifestyles. And so not just our patients are feeling, are dealing with the consequences of unhealthy lifestyles, but we as clinicians are often dealing with the consequences of unhealthy lifestyles. How are we eating? How are we sleeping? Are we able to set boundaries? Are we getting enough physical exercise? Are we driving everywhere instead of walking? Are we riding our bikes? Are we doing those things? And so we may be frustrated that we're seeing all of these additional chronic illnesses in our patients, but also dealing with them in ourselves, because the entire culture in the United States has, we're walking less, we're driving more, we're eating more fast food, and we have more inflammation associated with that, and also just the chronic illnesses that our population, including our clinicians and healthcare workers, are dealing with. So that's kind of where we've been. And let's talk about what's changed, the effect of the pandemic on the population mental health. So this is not news to anyone, and I don't have a lot of slides on this. We're going to sit here and talk about this a little bit for a couple of minutes. Is on a global scale, so not just for one group of people. This pandemic has really created a lot of stressors across the board. Isolation with social distancing, the loneliness and loss and grief of getting to celebrate milestones and other holidays and things like that. The actual bereavement that we're feeling, not just from the loss of those things, but from losing loved ones or seeing death rates rise, so that vicarious bereavement. Limitations on access to screening. So we know that healthcare workers aren't going to their visits. No one's really going to their wellness visits as much as they have been in the past. And so we're not screening for depression and anxiety as much, because people aren't showing up for their wellness appointments as much. Limitations on access to care. We've had, decrease in elective surgeries. We've had clinics shut down or changed to telemedicine. And that's not all. Telemedicine can be fantastic, but just that not having to change your routine, so it does limit your access to care. And then limitations on access to medications. When, can I get the right prescription? Is it filled at the right time? Does the pharmacy have what I need? With disruptions in different mailing and the postal service and all of that. We've seen increased alcohol consumption and substance use during this time across all groups, so our clinicians and our patient populations. Financial stressors, increase in domestic violence. A lot of people are locked inside their houses in distressing relationships, where those relationships might have been distressing, but you have a chance to get away from each other. So we've seen increases in child abuse and domestic violence during this time. The uncertainty of employment for us all, and then variations in schedules and processes. And I just think of this as constant adaptation. So I was talking with one of my kiddos' teachers the other day, and she said, I'm just exhausted at the end of every day. And I don't get it. Like, why am I so exhausted? And I said, because every single thing you're doing requires 3 additional steps now. Right? Did I log in correctly? Did I do this? I'm not sure. So it's 3 additional steps to do anything that you used to do. And what you used to do didn't make you untired by the end of the day either. So really important to realize that our brains, in this constant adaptation, I have this little thing on my computer that I have all the time, and it says there's no growth in the comfort zone and there's no comfort in the growth zone. Well, we have all been in a growth zone this entire year. And there's not a lot of comfort in that growth zone because our minds are constantly adapting. So really understanding the level of impact that not just one group of people is doing that, but the entire world is constantly adapting right now. So a lot of stresses. And then also, some of the media reporting, it's been very interesting. We're going to talk about that one of the techniques in using technology is knowing how to limit some of your technology, because irresponsible media reporting, whether that's through social media outlets or otherwise, that we've had a lot of divisive media in the last year, and that's caused a lot of problems. So let's talk about why clinicians are particularly at risk. So we talked about less autonomy, less creativity, less teamwork, less perceivable impact, high stakes, ethical, all of that kind of stuff. So and then when you think about that in the context of a pandemic, where we must use teamwork to get through, we must use creativity. And it is really, I think, this time where we've gotten to this place of using less of that, there's even more adaptation required and a lot of moral distress. So when we see what are the consequences of moral distress in clinicians, this thing called burnout, which I know there's a lot of discussion about whether we should even use that term, that there's burnout and or should we call it toxic work culture, because burnout seems to say, well, that's the person's fault for feeling burnt out. There may be something the person could do, and maybe the system needs to be the entity to change. But this is the defined word, the defined concept used in much of the research related to moral distress. So we see burnout, we see moral distancing, saying like, I'm just not going to engage here. And then attrition, people leave, they want to do something else. Also, this concept of vicarious trauma and vicarious bereavement. So vicarious trauma is really the idea that we are internalizing patient narratives over and over and over again. And what you can see is that you really feel triggered by, and you have changes in perceptions and behavior. This is not just like you feel empathy and you feel sadness, but it's more these stories over and over and over change the way you are perceiving the world. And they also may change your behavior. So I liken it to, we can use medical examples, but I also liken it to, if you're watching like those 48-hour shows all day long and you're choosing that, and I know a lot of people love to watch those shows, but after you've internalized those narratives over and over and over again of these, freak, weird serial killers or killer or whatever, that you start to think the world is a super, super dangerous place. And it can change your perception of who your neighbor is or might be. It can change your behaviors on how often you check your locks and things like that. So these internalized narratives can change the way that we perceive the world and the way that we behave. When you're doing that with someone that you're treating in a clinical environment, it's an even bigger impact, right? You're not seeing somebody through a screen. There's a little bit of distance there, or a lot of distance there. When you're at the bedside and you're really perceiving the impact of a trauma on a patient, whether that is the difficulty that they've had with their diabetes and now they're having to have an amputation, whether that's the sequela of a motor vehicle accident or a domestic violence or a child being abused, whatever it is, you are internalizing that in little bits and sometimes bigger bits over time. And it can lead to changes in your perception about how the world works, how safe the world is. So thinking about all that information coming in and what your brain is doing with it. It is associated with this lack of creativity, with apathy, with insensitivity and hypervigilance. So kind of being aware and on edge, but also feeling detached from that human connection. So being aware and on edge that something bad's going to happen, but being detached from the human connection. And that is the last place that we want our clinicians to be, right? We want them engaged, we want them empathic, and we want them calm. We want them to say like, hey, anything can come in and I can handle it. And so when we look at this vicarious trauma over time, very high likelihood to perceive to this hypervigilance and dissociation and sensitivity. So something that as a culture, we must look at and address as early as possible and teach people how to deal with these things and not just say, well, yeah, that's, I had there was a post on a group that I'm in, a physician group that I'm in, and it was an emergency medicine physician who lost an 11-year-old in the emergency center to consequences of COVID-19, and the child has multiple comorbidities. But she said, there was not another physician here. And I just went in another room and cried for like a minute and a half. And then I said, okay, let's get back. I got to get back to my patients. And you just thought, like, that is not the way we were actually designed as humans to process all of these things. But it is the requirement. And it's not just during COVID-19. It's not just during the pandemic. This is how, as a clinical healthcare culture, we're taught to deal with things. So there's lots and lots of opportunity. And one of the things about having a pandemic and kind of pushing us in this way is it's bringing a lot of these to light, and we're hopeful to use this opportunity to move many things forward that we should have been doing already. So the second thing is this vicarious bereavement, and Robert Kastenbaum has described this since about 1987 with these two types. So type 1, you can have intense grief and deep empathy and sadness, but you identify this, like, this is probably what they're feeling. I have a good friend. Her mother is in the ICU right now for consequences of COVID-19. She can't see her. It's very difficult. They're communicating via iPad. And when I talk to her on the phone, I'm like, okay, don't cry. I get off the phone with her and I cry because I think, oh my gosh, my heart is just feeling probably not as intensely what her heart feels, but my heart is hurting so much for her. And we all have that ability. And that's actually something we want in our healthcare clinicians, the ability to say, I feel as you do, but I also identify that I'm feeling as you do, that it's not my grief. The type 2 is the sense of personal loss. Like, I have lost something here. This is not, that you start to internalize that their pain is your pain. And that is the more, that's a fine line between empathy and then the ability to kind of be resilient from that empathy, or utilize the empathy to help inform the rest of your work, or getting stuck in that place, that sad place or that down place, and having that loss of ability to function. Or having fundamental changes in belief, like, this is a bad system, nobody is doing anything right here, which is not correct. I mean, those generalizations are never correct to say always or never or nobody or everyone. But definitely when someone's grieving, really grieving, we hear those kinds of statements all the time. So I want to talk a little bit about grief right now, and then we can get into what to do. But I think one of the most important things that we have to remember about grief is that it's nonlinear. So there's a physician, a family med doc in New York City, she has a blog called Fresh Perspectives, and I just loved listening to her description of grief as this Jeremy Bearimy. So if you've seen the what is that show? I'm going blank on the name of it. The Good Place, I think. And they explain the time-space continuum as Jeremy Bearimy, that it's all like, if you wrote that in script, that's what the time-space continuum is there, that it keeps jumping around. And that's what I think about as grief. Like, grief is not a linear process. It's never been a linear process. You don't go through stages of grief. You have different stages of grief, but then you go back to stage 1 or stage 3, or I don't even know if we should call them stages, because it seems like you move through them in a linear fashion, and you don't. You can get triggered by something and feel very, just overwhelmed very long after you had the incident that caused the grief. So I like to think of it as, you don't get over grief, you move through it. And hopefully you move through it and you don't get stuck in one place, but it's a loopy ride. And to think, to say, I started crying, 2 weeks later on a Sunday afternoon, well, that's the point in which time you got to the place that you needed to do that, instead of saying, oh, something's wrong and I'm not processing this and I'm not getting over this. I'm like, we don't really get over grief. We incorporated it. We use it. We want to use it to inform our empathy. And but I think I was thinking about the typical medical field teaching is, you need a clear head, be totally clear, be totally calm, don't ever lose it. Don't cry, don't be impacted by these things, that we can handle anything. And it's just not the way our brains and hearts actually work. So it's really leading to this, or has led to this, what is described as an unhealthy stoicism. Like, I'm fine, nothing impacts me. It's like, no, you're detached and you're dissociated, and then actually can make you a worse clinician. And so really important that we talk about that. So what to do. And first, I want to say we screen. We need to intervene early and often, and we need to build resiliency. So when we think about screening, if for the patient population, we absolutely know that there is tons of evidence about screening every single time a patient comes into the office. So you come in for a wellness check, you get a depression and anxiety screen. You come in for the flu, you get a depression and anxiety screen. And we know that if you screen and that you follow that over time through treatment, that all of your medical illnesses actually get better. You have better outcomes for diabetes, for hypertension, for cancer, for everything if you've screened and responded to depression and anxiety. So really, that evidence about the importance of screening and responding to that screening is well demonstrated. We don't always do it. When we look at some of the metrics that we're required to do, that screening is a part of it. But when I talk to people about what happens after the screening, a lot of times the screener just gets scanned into the EMR and no one's actually responding to it. So screening is super important. Being able to do something is very important. But when we think about clinicians, we really need, and maybe for all of us, all humans, we need the ability to screen at any time. And so I really like this app. This is an app that was developed through the VA, and it's called the Provider Resilience Dashboard. This is actually my score when I was coming off a vacation. So pretty good. It was a pretty good score that day. But I think what I really love about this dashboard is it gives you, it's really quick that you can click through several questions, and then it will give you a score. It will give you this resilience rating. Now, what happened, and then it will trigger you to do it again. Like, hey, you haven't done your resilience dashboard in a while. Like, I got a text yesterday, like, time to update your resilience dashboard, and you fill out these things. And what you can do if you're doing this regularly, if you're utilizing this app, once you can look and see if you're moving towards low, right? So we're trying not to wait till we're at low to say, oh my gosh, something's wrong with me and I need help, or I need some intervention. That the goal of wellness is intervening as early as possible. Well, to do that, you have to screen. You have to screen a lot so that if you're moving from green to blue. I mean, it says I'm in green, but it has me in a blue here. I don't know. But that you're moving from green to blue, or you're hitting that yellow. And what an easier place to recover from the yellow than if we're down in the red, right? And so we want to know if we're in the red, absolutely, but we really want to follow this over time. So I like, this is a free app. Anyone can download it. I would really recommend everyone to do this, because to me, this is an easy way to screen. The other thing is that it does have some feedback in here where it'll say, hey, it's been, so here it had been, not very long since a vacation, but so 24 hours, because I was coming off vacation or whatever, but it will tell you, like, it's been this long since you've had an off day. Like, you need an off day. So I really like this app. I think when we're talking about technology and things to help us, the idea is not to make this difficult, not, oh, you have to make an appointment with your physician, because we know that healthcare workers are really, really bad at that. We're very busy. We're very busy taking on everyone else's trauma. And we're not really good at addressing our own, even just general healthcare needs. So this is a way to have this in your phone, and it lets you know how you're doing. So I think this is really important. And even here, like, my compassion satisfaction here was pretty high that day. My secondary traumatic stress score was pretty low. Now, I can tell you this has been different. I mean, I've come out of clinic or come out of on call, come out of the hospital on days where I've seen horrific things, and my secondary traumatic stress score has been higher. And then I think, what do I think? I think, wow, I need to take care of myself better today. I need some additional self-care, right? But if I'm not doing this, I don't even realize why I snapped at my children when I got home. Like, I don't know why I did this. But when I do this, I go, oh, that's why I snapped at my children. Or maybe I even say, maybe I need to take a walk around the park before I go home. Like maybe I need to do something else. And so that's really the benefit of having a screening instrument like this that also gives you some real time good feedback and can compare things over time. So I want to talk about intervening early and often. And this is really what I was talking about with screening, is that we would like to intervene. If we screen, we can intervene at a lower time, right? Not everyone needs specialized services. And a lot of times, especially with mental health, we think of intervention as an appointment with a psychiatrist, where there's so many more opportunities for intervention before that. And I'm not suggesting that you shouldn't see a psychiatrist. I mean, I'm a psychiatrist. I think we're fairly nice. I think we're good at what we do, and can be really, really helpful. But we would like to intervene. There are many, many, many other opportunities for intervening way before that point. And if we're screening and we're getting that feedback, we definitely can do that. So when I say intervene early and often, it's really first you got to screen and see where you are. Then you say, okay, hey, what kind of social considerations do I need? Am I doing too much? I mean, when I think about this, I think, how many activities are my kids in? Right? Am I running from work every day and then I'm overwhelmed with everything that we're doing in the evening? Like maybe I should change that a little bit, you know? When was the last time I talked with my family? When was the last time I called my dad and had a conversation, or my mom and had a conversation? I actually just recently put a reminder in my phone that just said, have you texted or called a loved one today? Because I realized, like, in all of this adaptation, I was so focused on what the next crisis was to do that I wasn't connecting with people. And so I just put that reminder in my phone, and it's great. Now I'm doing it almost every day, and I'm like, yes, I've already done that. Leave me alone. But that's good. That's better, because at the beginning, I was like, no, I haven't talked to my friend who lost both of her parents in the past year and is probably really struggling, and I'm worried about her, but I haven't actually checked in. So, you know, there are lots and lots of ways to support our mental health and use technology and apps to do that. And then, so when we talk about other direct interventions, I want to talk about, you know, for those people I say here at Texas Tech University Health Sciences Center, and most other major organizations, you have something called employment assistance programs. And these employment assistance programs provide direct clinical service. And that can be a therapy, it can be a referral to a psychiatrist, depending on what services are available at your institution. But the greatest thing about EAP services is that they're informed, right? Like they're hired to be the support for that institution. So if it's a hospital or a medical school, they have hired people who are used to working with that population. So when you have somebody who's trained specifically in what it might look like to be stressed out in a pandemic as a healthcare worker, they can support you in a way that's more direct than many people who actually have the same credential but work in a different environment. So I often recommend starting with an EAP service, because you might not need a 16-week course of therapy. You might need to have 4 sessions where someone can just hear what you're going through and get some specific feedback about what's worked for other people in that same environment. So I really like the idea of EAP services, and later I have the number for our one here. And then when we look at some other things, like not all places have this, but what's called a moral distress consultation service. So some hospitals do have that, where the clinician is just feeling morally distressed and burnt out or battle fatigue or whatever you want to call it. And they can call that service. So it's like a spinoff of the ethics service. But really, we know that when we support clinicians who are feeling in that mode, that our healthcare outcomes get better. And so a lot of hospitals are moving towards that, and I would advocate for that service, and also, you know, advocate for looking at if your hospital has that service. There's some writing retreats that have good evidence for just getting together for those people who like to emote through writing and writing about their experiences and being able to share it. And that's a really easy thing that you can do on a unit-based kind of intervention. And then moral distress mapping is another kind of thing, talking about, like, why am I frustrated? Like, try to see where that's coming from. There's a really great program from the American Association of Critical Care Nurses that's just the 4 A's, and it's focused on what nurse managers can do for their units. And it's pretty simple, right? Ask, affirm, assess, and act. So ask, like, are you okay? That is what they're asking. Like, are you okay? It's not that hard. Just ask that, because it normalizes that you might not be, right? When we don't ask, we assume like, oh, we're supposed to be okay in all these situations. When we ask, like, hey, are you okay? It's been a hard day. Hey, it's been a really hard week. Are you okay? It normalizes that maybe you're not. And so it opens the door to having that conversation. And then affirm when someone says like, no, I'm not okay, instead of being like, well, you need to go to therapy or you need to do this, like first to say, yeah, this is hard, right? And so affirm that this is hard, and that for that person, no matter where they are at what point in their career, that whatever they're dealing with right now might be really, really overwhelming. And then assess. I mean, you do want to assess at what level. So is this a crisis situation? Are we finally asking the question and the clinician we're speaking with is feeling super burnout and about to leave or harm themselves in some way? Or is this really like, I need like an hour, or I need 5 minutes, or I need a day off, or I need something like, so kind of assess where we are in the situation and then act on that. So it's not rocket science. It's really, I mean, it really is straightforward, but there's a lot of evidence behind these 4 A's and improving the mental wellness of our clinicians, which then improves our healthcare outcomes. So it's really important to the hospitals that we have wellness in our clinicians. And then we want to build resiliency. And we're going to talk a little bit more about what resiliency is, and then how we do that on an individual level, and then what institutions need to do to support that as well. So first, resiliency is the capacity to recover quickly from difficulties. And we're having to do that over and over and over again. Everyone's doing that in the pandemic, but we all have to do that, especially as healthcare workers, with or without a pandemic, right? And I think of it as, it's a balloon. We would like, in a perfect world, to be this very thick-walled balloon, and somebody pokes us, and then the poke goes away, and we reinflate, right? But if our balloon is really full, we're able to do that. If our balloon is not, and it's less full, then we might not come all the way back out, and our elasticity may be changed. So think about that. So yeah, I already gave that example. So just the ability to recover that size and shape is my balloon example. So when we think about individual resiliency building strategies, the first is promoting real self-care. I was talking to one of my dear friends about this presentation, and she said, if you tell me to take a shower, I am going to lose my brain. I'm going to lose my mind. Like, I've taken a shower. And so really thinking about, this isn't about having a good meal or one girl's night out or one vacation or that kind of thing. It's really about day-to-day things that you can do to build that resiliency in yourself. And one of the things that I would say is to edit that incoming material as much as possible. We're going to talk a little bit about that, but there is so much on social media. There's so much in the news. There's so much information that we're getting. And a lot of it is negative. A lot of it is divisive. And most of it is not relevant to exactly the moment that we're in. Right? Do I need this information right now to make any decision that I need to make? Nope. I need to drive home and make dinner for my kids. I need to do something, do I need to know all of this information right now? And so edit that incoming material as much as possible, and see where you're getting your news. I'm not suggesting you shouldn't have news. I think it's very important to be an informed populace, but we can talk about some apps I recommend, or some websites that I recommend. And I have no stake in them. They have no idea I'm recommending them, but just to be a source of news that's a little bit more or less partisan, less divisive. Then setting boundaries. I think especially in a crisis, as healthcare clinicians, we're used to just fixing it, right? I want to do what I need to do, and there's no end. The crises are endless. And we cannot function like that. That is not a healthy way to function. And so you have to learn to set boundaries about prioritize what the real crisis is right now. What can I truly address effectively? Because when you're addressing all the things, you can't be effective. So to really set those boundaries for yourself, and do those cast in stone, identify those cast in stone things for you. So what are the things that you must do to keep yourself healthy? For me, it's playing tennis. I like to play tennis, and it's spending out time outside with my kids, right? So if I don't play tennis and I'm not spending time outside with my kids, if I have, put a meeting there, then I'm not getting to do that thing that preserves my self-care. So we, mantra over and over, it's not selfish, it's self-preservation. So we have to do these things. So what are those cast in stone things for you that do not move off of your calendar? Put them on your calendar. They're not afterthoughts. They're important. They are the priorities. And then everything else goes around those. Improve your self-preservation skills. So this Lori Santos, which I'll talk a little bit about her in a little while, does this great Science of Wellbeing course and talks about checking your reference points. This is another thing with social media, that if you are looking at these beautiful Instagram feeds, you're like, oh, look at their wonderful life. Listen, this is when you have to remember that you are comparing your behind the scenes to everyone else's highlight reel. You have to check your reference points. And I tell this story, I know I'm running up against the time, so I'm going to try to go a little bit faster, but I tell the story about a couple of months ago, I was driving to take my children. We had quarantined. My mom really wanted to see my kids. We were meeting in between Dallas and Lubbock, and I was driving on a backcountry road to meet her and got into this gravel situation behind a car. Anyway, 7 cracks in my windshield, 7. And I was like, oh my gosh, in a minute and a half. Of course, then I slowed down and So I got back home. I didn't have my kids there. My husband was amazing, got my windshield replaced in 2 days. I go pick up the kids. I'm driving back, and another rock hits my window and cracks it. Within a week. And I don't think I've ever had a cracked windshield. And I was so angry. I thought, if I hadn't replaced it this week, I would only have to replace it once. I can't believe this is happening. And my 9-year-old said, but Mom, what if that was the rock, that last one that shattered this, and it hurt us? And I thought, oh my gosh, yeah, I need to check my reference points, right? I have to change my windshield twice. So annoying. And not realizing it could be much worse. Things could be much, much worse. So really checking your reference points is super important. It immediately changes your mindset, immediately. And so that idea of being grateful for your situation because it could be worse, I think is actually a really, really important exercise. And then self-care is healthcare, right? Exercise, what are you eating? How are you taking care of yourself? Really, really important. And then safety plan for emergencies. And I'm going to give you an app to do that because you are the most valuable resource and we have to protect you. So here we go. Some apps that I do recommend. Or some websites when we're talking about utilizing technology. This is ZDoggMD. I don't know if you guys have heard of him, but I really think, he has this, so it's called Healthcare's Unfiltered Voice, or he has this other tagline about being alt-middle, which I really, really like. So, just really trying to find the truth in all of the noise. There's so much noise, but what is the truth here in all of this noise? And advocating for the healthcare worker. So I really think that's a great community to be a part of. And then the other thing that I found recently is called Smart Her News. And the goal of this news site, it's a woman, and I don't know all of her background, and I apologize for that, but her goal is to present news in a nonpartisan way. And I just love it. And in bite-sized forms. So you can follow on Instagram and they'll have these bite-sized forms kind of as it is here, but then it'll link to her website where you can read more about it. It's all free. And so it's really, really great. The Happiness Lab is Lori Santos's podcast. And I referenced Lori Santos before. She is a psychologist at Yale and has developed this course called the Science of Wellbeing. And you can actually do this course. I've been hearing about this course for several years and thinking in my head, how could I take a sabbatical to go do this course at Yale? And then in the early pandemic, they put it on Coursera for free and did it as an online course. And so I had the opportunity to actually lead our residents through this course. And I don't know who it was better for. Probably me. It's where I learned this reference point thing and taught my 9-year-old, who could help me later with it. And but really also talking about there's so much great information, evidence-based information on there about what actually makes us happy. So the point of a lot of Dr. Santos's work is that we have focused our entire mental health industry on the absence of pathology instead of the presence of wellness. And I really like her podcast because it's about wellness. Now, Weight Watchers, a lot of people have heard of this. I started doing this during the pandemic because I realized how much crap I was putting into my mouth, actually. And I needed some help, just helping me realize, like, what are you doing? And it's helpful for me to do it on an app-based kind of thing. And it's phenomenal because it also has these built-in exercise things. So you don't need to use this. I'm not advocating you use this one in particular. I'm just saying that this was helpful to me, a technology source for me to improve my healthiness and my wellness overall through exercise. And I can track my exercise and track what I'm eating. And I really feel like it's a great opportunity. There are many different other things you can do. You can do this on your own. There are free apps to do it with. And then two other things I want to talk about. One is the CBTI Coach. This is a free app developed with Stanford and the VA. And it is really cognitive behavioral therapy for CBT, and then I is for insomnia. So this app is actually based on tracking your sleep over time, but because it's CBT, it has all of these cool techniques in here. So changing your perspective, this breathing tool, the progressive muscle relaxations and guided imageries, and you just press a button and it walks you through all of it. And it's a free program. So you can look at that under tools and just skip all the sleep stuff or use the sleep stuff if you really, if you're having trouble sleeping during this weird time where all our schedules are different. And then the My3 app is the last one that I think is super, super important. This is a safety plan. So if you pull it, it's free as well. It's based on evidence for safety planning for suicidal behaviors and suicidal ideation, that it'll have your numbers in there. You can program them in there, but it also says, like, hey, if you're feeling like this, here are some techniques to do. And you pre-program that when you are not feeling down or desperate. And because when our brains go to that super emotional place, we have left our thinking brain. And we often need something, we need to look at something that says, and that's why safety plans work, because there are thinking brain talking to us when we're in our emotional brain. So the My3 app can be really, really helpful as a safety plan. You just have that on your phone, you can email it to people, all of that. So again, there's this Be Kind to Your, this is Headspace for all clinicians. This is free right now. This is a meditation kind of thing. When we were talking about how you deal with this vicarious bereavement over time, there's this concept of mindful, compassionate detachment, that I can be present, and I can be empathic, but I don't have to absorb everything that's going on with you. And that is a skill. And that is not second nature to us. And that's something that you must learn and that we must teach. Atul Gawande has this great book, many great books, but one of my very favorites is called Being Mortal. And I think, what I love about this is that it's the commentary that both patients and clinicians are mortal, like we're all human. I think it's a really good commentary on mindful, compassionate detachment. And then the headspace. So, and then when we think about cultural resiliency building strategies, this is really about how to build community and relationships and teamwork, and feeling like you're part of a community. I was speaking the other day on healthcare worker mental health, and I said, we have gotten through as a culture so many different things, wars, all kinds of different things. When we feel like we are together, we're working together, we can do almost anything. It's the isolation that makes everything feel overwhelming. So the idea, resiliency really relies on the culture of teamwork and relationship. And then institutional, I'm not going to read through all of these, but there is a lot of information out there, a lot of evidence-based information on how to improve moral distress recognition and the benefits of preventing and responding to it, and really on a unit-based place. So, not to do it for everybody the same way, but to look at the way you're working in your unit and look at the opportunities there. So I think this is my last slide, and then maybe we'll have time for a little case presentation, but I want to talk about that this is, we'll be okay. We've done hard things. We can do this together. And there are many great things still out there. I also want to say that there is help if you need to seek help, and that we need to look at these things. If you've had an increase in symptoms, a decrease in your functioning, feel the need to use or overuse drugs or alcohol, and especially any thoughts of harm to yourself or others, that it's a time to reach out for help. And the earlier we do this, the less intense that help has to be. We can make this, I don't know if all of these slides are available to everyone, but I'm sure we can send this out if we can. I mean, through the RCH, all of these different numbers, but there are lots and lots of different numbers to help with support. And then here's the list of the app-based resources that I had. So just references, and then I think we can get to maybe one case presentation. If I'm going to present this, I just have one slide for each. There's a nurse presentation and a physician presentation. And I would love feedback on what you guys think we could do, or you can just think about it. But I think this is a great opportunity for discussion and collaboration. But so step down unit nurse, so ICU step down, experienced mid-career registered nurse, worked on the floor more, in early career, more recently, last 2 to 3 years on the step down unit. Now in a Tyvek suit all day long, 12-hour shift, not urinating, not hydrating, actually went to the emergency department because during their shift was so dizzy and got dehydrated. Drastically, like witnessing a drastic increase in number of deaths, especially in a smaller time frame. And then also of patients, witnessing deaths of patient under their direct care. Tearful to and from work most days of the week, considering other options for employment, but feels obligation to colleagues during this time. Like, I don't want to abandon them. I don't want to leave right now, but I don't know how much longer I can do this. So you can feel already that thought becomes a fairly desperate thought pretty fast. Like, I feel trapped because if I leave, I feel like I've morally abandoned my colleagues. And if I stay, I don't know that that's a good thing for me. Increased alcohol intake when not on shift, sleep more erratic, wakes up multiple times per night, concerned about kids still going to school during the surge, but unsure how to make it work without that option. Like, how am I going to work if my kids aren't at school? I don't know how that's going to work. So I know we're kind of running out of time, but I'll be quiet and see. I would love, based on all the things we just discussed, what would you guys recommend?
I think, as you mentioned before, with the importance of self-care, I think it's important that this nurse makes sure that she does have some time for self-care so she can be a little more resilient.
How do you do that?
I think, like was mentioned before, just make sure you schedule it into your schedule, whatever like is important for her, whether it's spending time with her kids, outside every day for a little bit of time.
Thank you, Christina, for that suggestion. If after listening to Dr. Wakefield's presentation, I would probably tell to this nurse probably you probably had to download some apps. Number one, number two, probably you have to check your provider resilience dashboard, because sometimes this moral distress is unaware to the person. Like, I could relate to this, that, having that PPE on, and I don't want to waste them. So sometimes I have to hold those bodily functions. It is what it is. And sometimes, we are beset with compassion fatigue, moral distress, ethical distress and whatnot. So sometimes we had to be told by somebody, or so sometimes we had to be, kind to each other and essentially take care of each other. So these are sometimes our, moral and ethical obligation to make sure we take care of each other around us. We are all in this together, right? So what do you think, Dr. Wakefield?
No, I agree. And I think sometimes just the permission to do so. You know, we really exist in a culture where and it's hard to know exactly how we got here. There are lots of different theories where we are supposed, you know, I think about this. I take care of pregnant postpartum moms too. And I tell them all the time, like, we were not designed to have babies inside a house where we never talk to another person. Like, we were designed to have babies in huts where like multiple generations of lots and lots of women are over there helping you. You know, you can pass your baby off and sleep. And so that is, we are designed as relational beings and to check in on each other and to help each other and to step in. But this, you know, this autonomy and sometimes like a toxic way of like, I am responsible for all things. All of it is on me, really can get in the way of our mental health. And so I think just that permission, that cultural permission that you do have to take care of yourself. That's why I love that mantra of like, it's not selfish, it's self-preservation. And then putting those things in your, you know, doing the screening, having the apps. But I think you're absolutely right, Christina, the putting it in your calendar. You know, when are you going to do these things? Not just having the idea that you should do these things. When are you going to do it? And holding yourself accountable and setting the other boundaries to make sure it gets done. But having somebody who is your supervisor who's also checking on that, like, hey, put that in your calendar right now. Did you go outside with your kids? Did you do it? Because it is important to me as your work supervisor that you are taking care of yourself. You know, that's the culture that we want to get to, that we're holding each other accountable for our wellness, because that improves the overall system.
I would like to ask Dr. Edwards as well. Dr. David Edwards, are you available for a comment or question? Well, I'm not hearing it, but Dr. Wakefield, you know, it seems like there is a 35% increase of anti-anxiety medication, as well as 22% increase in intake of antidepressant, plus, you know, bad combination increase in alcohol consumption. You know, what do you think about this? Is this a trend going on in the psychiatry world, or you know, or people are self-medicating?
Well, I think first we have to remember that most antidepressants and anti-anxiety medications are actually prescribed in the primary care world, and so with your primary care doctor. And I really, you know, my perspective is that that is because our access to other services and also our education about mental wellness is overall lacking. That we really have relied on medication as if, again, I'm trying to get the absence of pathology, not the positive idea of wellness. Yeah. And, you know, there are antidepressant, those types of medications can be very helpful if we have a diagnosed clinical depression. But what's very interesting is that, yes, all of those prescriptions have increased at all of those stated rates, and our suicide rate is still increasing in our country. And so it's not correlated with a decrease in a death of desperation, which is really what we're trying to, you know, what we want to do. So we have to look, like, the answer is not in a pill. A medication may be part of the answer. I don't want to say that a medication is not part of the answer. It absolutely may be part of the answer, but that it's not the only answer. And that mental wellness, well-being is much more complicated than addressing one neurotransmitter in your brain. So you might need to address that neurotransmitter to make everything else work, but it's not the only thing. And I don't know if that answered your question, but I really think we have an opportunity to look at the science of well-being and to promote that at multiple levels, cultural, individual, institutional, and we'll see better outcomes.
Thank you very much, Dr. Wakefield. I'm really, really very grateful, you know, for this talk. I've learned a lot, and as a surgeon, these are the things that I don't usually study, and but these are the things that I experience, you know, bereavement, grief, and whatnot. Thank you for normalizing all these emotions for us. Any question from the crowd? Thank you very much, by the way, for attending. Any questions? You could type in your questions. You know, if you're bashful to speak up.
Hello, Dr. Wakefield. A great presentation, by the way. I just wanted to say, during the case study, I really liked the way that you explained how like you need to take care of yourself and everything. And I also thought back to a previous slide that you said, the 4 A's, the act, affirm, assess, and then act,
Yeah.
which is really great. And I thought that, you know, in that case, you should definitely ask like, is everything all right? See like how you can relate on that level and stuff. So.
I think that's fantastic. You know, it is amazing how much, if we just understand someone else as a shared experience, that we feel less alone and isolated, right? And so,
Yes.
so often we're feeling like, I feel like this, so something's wrong with me. Instead of realizing like, this is just a stressful situation, and it doesn't mean that anything's wrong with you. It means, I was saying the other day in a different discussion that it's not a sign of weakness to be stressed out in this situation. It's a sign of humanity, and humanity is a good thing. Like we want to be a part of humanity, but it is, you know, there are things about the culture of medicine in particular that have not lent itself to supporting that in the past, and this is a great opportunity to start changing that tide.
Absolutely.
Dr. Edwards, any final comment?
Hi, everyone. Thank you for that presentation, Dr. Wakefield. I'm sorry I missed part of it, seeing patients, but thank you for these resources. And, you know, the old adage, physician, heal thyself, is very pertinent, and you've given us the tools to help us in that process. So thank you for that. Much appreciated.
Well, it's been my pleasure. And like I said, we can definitely, I left this slide up here, and then this one's also very, very important. Texas has done a great job of providing some resources. We have them at TTUHSC, and our counseling center here, which is under our psychiatry department as well, serves as EAP for many places in our community, UMC and the city of Lubbock, and so many different places. So I would recommend, please, there, we also have a resources page on our website that has a lot of resources, podcasts, all kinds of things. Like I said, if we intervene early, we can intervene less.
All right, we will have these slides and this recording available in the future, and we will email you Dr. Wakefield's slides. By the way, don't forget, next slide, don't forget to fill up your evaluation in order to get the appropriate credit. And we would like to wish you all happy holidays.
And we're going to send that slide out also.
And we will send this slide to you as well. And
Yes.
This is kind of fancy. You just put your cell phone in your camera, and you will get this evaluation right away, the QT code. All right. Thank you very much, Dr. Wakefield.
My pleasure.
All right. Goodbye, everybody. Thank you.
Another fantastic one.
That was very